But if you do want to talk about a question or whatever, because you're trying to compare the two, just come up. We can talk on the break, and I'll try to, so that way we don't confuse everybody. But everybody may test differently, and everybody may give you that information differently. I tried to line mine up with PEDS, and then after the semester, I'm going to also make sure that it lines up with what we have with HEAT. I'm going to give you the very basic thing that I want you to do, and we're going to talk about that now. So looking at this, we have several different bugs, right? We already went over the fact that my first drug that I'm going to try is going to be amoxicillin, okay? Don't need you to remember the dose of amoxicillin. I'm not worried that you know that. Now, if I have had amoxicillin already within the last 30 days, if I have conjunctivitis, or if you see that it's positive, and I'm not going to ask you this, but if you need some beta-lactamase coverage, which I could ask you that way. If you need beta-lactamase coverage, any of those three situations, that's automatically prompting you to say, hey, I need to use augmentin, okay? Straight paper, yes.
So you would prompt us with, like, we don't need to know that they're beta-lactamase positive patients.
Like H. influenza, M. cholerae, I'm not going to ask you the bug. I would say there's some bug that produces a beta-lactamase, right? And if you have a beta-lactamase, you should always be looking for a beta-lactamase inhibitor. So we know that that is going to be our clavulanate that's added to our amoxicillin. If I just gave amoxicillin with this beta-lactamase producing bacteria, is my drug working or is not working?
It is not working.
Not working. What is my beta-lactamase doing to my beta-lactam? Cutting it up, right? So that's why also within the 30 days, I've opened up my playbook. Now you know what plays I'm running, and because it's so soon, we will try with something else. Okay, so that's why that's why we use the augmentin. Okay, so remember those three situations. Another thing that you can see happen is, and typically this is something that we do if it's been a while or they continue to get ear infections, we will do the ceftriaxone injection, and it needs to be over 3 consecutive days. So if it's a Friday, and you're not open on a Saturday or Sunday, then you need to start that treatment on a Monday. My nephew used to get a lot of infections before they did the tubes, and they kept putting them on antibiotics, amoxicillin, augmentin. They did different cephalosporins. Then they tried the ceftriaxone injection. Literally a month later, every month almost, he would have an infection. And they did that for 2 years before they even did tubes, which I was like, that's a long time to be on antibiotics. So understand that this is like an escalation, and this can vary depending on what that provider chooses to do, okay, and how they want to escalate that, which is what you guys are learning in HEAT, which is also what you're going to see whenever you do PEDS. So for basic PHARM, applying the drug, amoxicillin is my drug of choice. If I have that use within 30 days, if I have my beta-lactamase, or if I see that they also have conjunctivitis, that's when I'm worried and I'm going to do augmentin. Or I can do my ceftriaxone for 3 days. If they have a penicillin allergy, okay, granted we have that, and we're talking about our cross-reactivity. What I want you to know is that the ones that have the least amount of cross-reactivity, even though they're cephalosporins, remember I told you there's a chart that they have, and it gives you like the side chains of all of your cephalosporins, and it tells you the likelihood of a person with a penicillin allergy also reacting to a cephalosporin. So these are our ones that have the least amount of cross-reactivity with someone who has a penicillin allergy. So we have our ceftonir, you have your cefuroxime, cefpodoxime, or your ceftriaxone, okay? So this is just if there's a penicillin allergy. So I would tell you, your person can't tolerate penicillin, or I would say, hey, they had some type of anaphylactic shock, we're not gonna give them penicillin, right? We're gonna go ahead and move to one of our allergy alternatives that we have. And then that severe penicillin allergy, that's where they almost died though, right? When we're looking at our low chance of cross-reactivity and like the penicillin allergy of like, and that was me, I just misspoke, our penicillin allergy where I just had a rash, or the like just hypersensitivity to the drug versus like shock, anaphylaxis, then I'm looking at my, I say AC, so azithromycin, erythromycin, and clindamycin. which one, if I had to pick from these, which one is the, like, my third line one of what I would want to try to avoid? Why am I avoiding my cleanliness? C diff, right? So like, you can have two correct answers, so to speak, right, that can treat something. You're always looking at what is the most important, because you're gonna have all of these drugs available to you. I'm giving you 5 choices. So sometimes there may be oh, this could work, but this is the better thing, right? It's my first time having an ear infection. I come in and let's say you see augmentin and you see amoxicillin. What's your option? What's your best choice?
First time?
First time, amoxicillin, right? There's no reason, I didn't tell you any of those 3 things as to why you need to give me augmentin. There's no reason for you to do that. Even if I had one last year and I'm coming this time, clearly it worked last year, maybe it cleared my ear infection, and now I'm back this year and I have another one, I can still use amoxicillin, okay? So don't automatically think, oh, I have to jump to augmentin. If you see 2 things like that there, sometimes there's still a drug of choice, there's still a first line that you're following that you're gonna pick, okay? And then looking at this down at the bottom, if they're less than 6 months, so sometimes we have what's called watch and wait, right? We don't always have to treat. My daughter gets ear infections, they tell me all the time. She never has any symptoms, asymptomatic, and then she has brittle bone disease, so I don't want them to like be digging or putting tubes or anything in her ear. So I tell them, hey, I don't want to keep her on antibiotics year round, so we just watch and wait. And every time we go back, sometimes they say, oh, it's gone now. So we don't always have to treat. Just because you see the ear infection, it doesn't mean that it can't sometimes clear itself. So with her, she clears herself. I don't put her on meds. So if they're less than 6 months though, you are supposed to be treating that patient, right? Because they're little, they're too little. All right, so that's all this is saying, less than 6 months treat. So I put everything in bold that you really need to know. I guess I need to bold next time, your penicillin allergy versus your anaphylactic. So for severe, for you to remember, write anaphylaxis, and I'll add that next time so that there's no ambiguity about what we need to do when we see severe penicillin allergy, okay? So this is, they almost died though with your severe AC. And then the other ones are just like, oh, I had some type of hypersensitivity. What are my other options that I can use? Yes.
Maybe they're 6 months still amoxicillin.
Yes. Yes. We love amoxicillin for acute otitis media. This is the same things that we were talking about, like if they have several episodes of this happening. So if the same symptoms occur, then you can prescribe typically the same antibiotic. The only exception to this was if it was less than that 1 month, right? So that's where you'll see that I'm adding in that augmentin, which is that second bullet. And then if they have more than 3 or more episodes in 6 months, 4 and 12 months, then you can refer them because they're probably gonna get tubes. This is what guidelines say. In practice, most of the time people don't keep track, or if I go to several different doctors and I can't remember how many ear infections and what the time frame was, that's also where you'll kind of see some ambiguity in this happening also. Okay, so what I want you to know about are these first 2 bullets. That third one is, again, just clarification and completeness. Okay, so this is just looking at what your treatment algorithm looks like. I've already told you the big highlights of what I want you to know. The other thing is, depending on what's going on with that patient, typically we're treating them for 5 to 10 days. And they'll take that amoxicillin twice a day. You can put this one in the refrigerator. It helps it taste a little bit better for the kids. And also, I typically think that dosing them on the higher end, especially if you have someone who tells you that their kid spits their medication out a lot, or if somebody tells you that their kid like throws up after taking medication, if you give them that like to where they have enough left over to redo a dose when that kid spits it out, that kind of helps them out and not have to come back to the pharmacy or have them on the end of where they're like, oh, I didn't have enough meds, so I stopped ahead of time. I didn't get my full 5 days of treatment. I had enough just before. Okay, so then that's where we see some of that resistance happening with our kids. So you see that like you have that range of 80 to 90 mg per kg per day. But with that, like I said, sometimes we'll go towards that 90 because it just gives us that extra buffer if that kid did spit it out. Don't need you to remember the dose. I'm just showing you how the algorithm kind of works. So this is a good reference for you to look at whenever you're talking about what are my different alternatives that I have, like a summary chart of what we talked about before. So if you want to see it in just words, just look at the antibiotic over there and then look at the title. So your first line agents, your alternatives, and then your severe allergy, like your anaphylaxis, okay? This is telling you the same exact thing that we saw on that very first slide. Okay, pneumonia. We kept talking about pneumonia. We were talking about CAP, HAP, VAP. And then if you had a person who had CAP or your community acquired, I could choose to treat them on an outpatient basis or I could admit them into the hospital. So that's what we're looking at. You see all of these different types of bugs that we have. Typically, whenever you're looking at your CAP, we can say like, hey, if we call it CAP if they've been in the hospital less than 48 hours. So if we've diagnosed them with pneumonia and they haven't been in over 48 hours, we consider it and we'll call it CAP. If they've been in the hospital for over 48 hours, then that's when we take the responsibility and we will call it the HAP, because that's us. And then the ventilator, same cutoff. If they've been on the ventilator for over 48 hours, that's whenever we will classify it and say that it's back. Okay, just giving y'all some extra information. But this is all of your different bugs. Again, I'm not gonna just say like, hey, what bugs? What I wanted to point out here is that infection with MRSA or Pseudomonas, typically when we're looking at pneumonia, we are not worried about that. If they are in an inpatient setting, that is when we become more worried that, hey, maybe I do need to treat for the MRSA and the Pseudomonas, because remember, all these other people in the hospital are also kind of sick, right? They're probably carrying our big bugs, our bigger, more resistant bugs. So sometimes if we see a HAP or a VAP, you'll see where we're like, okay, let me go ahead and try to treat them, bless you, for Pseudomonas and MRSA as well. So that's one of the things you'll see whenever we're looking at our algorithm. So this is your CAP, and this is your outpatient algorithm that you're looking at and kind of saying, all right, what do I need to do to treat my patient, and I'm going to send them home. I don't need to admit them. So they came to clinic, they came to the ER, and they're telling you like, hey, I'm not feeling well. You're going to diagnose them with pneumonia, and then this is what you're going to start treating with. So you see like our drug of choice, what is preferred. What did we just talk about? Amoxicillin. Okay, so now we have it for two different things. Okay, that's our preferred med, and then you're just picking one of these. Okay, so they're just on this one drug. Then you have your doxy, your azithromycin, which can be given as your Z-Pak, or you can give them 500 for 3 days. Remember, we had that long effect even after they stopped taking it, so they're still going to have some of that coverage if I give them that azithromycin for just that 3 days, which is why we sometimes, depending on the provider, they like to just go with azithromycin instead of our amoxicillin, but amoxicillin is preferred. It's just every 8 hours that they're taking it, because you see it's 3 times a day. So not as convenient. Then you see your comorbidities listed over here to the left. So just think about, yes, sorry.
So we have amoxicillin, doxy, and then is it kind of in that order of preference?
Yes. So what I have seen, again, the amoxicillin is usually where everybody goes first. Some provide, it varies based off of the provider. I have some preceptors who they will do azithromycin and they like the 3 days. They don't do the Z-Pak, they'll do the 3 days of azithromycin because it's shorter and they're taking it once a day, like it's easy. And then I have some people who like doxy. It just depends on like what you end up preferring. Test purposes, your first line is typically what I'm asking you about, amoxicillin. Real life, you're gonna pick your drugs that you like for your disease states, and you're gonna be like, I don't really like to use doxy. I have the ID pharmacist. Sometimes she'll be like, I hate Clinda. Like, I love Clinda, but I hate Clinda. You'll have somebody else that's like, yeah, I treat them. You know, I love Clinda, and I just watch them and tell the patient to watch out to make sure that they're not getting C. diff. Like, cool. So it's the provider's preference, and depending on who, like when you're in phase 2 and you're doing rotations, depending on who you're talking to, they're going to tell you like second line what they would prefer more. But guideline wise, amoxicillin is what we're supposed to start with. And then so your comorbidities are to the left. Think about like your very sick patients, heart issues, lung issues, they don't have, their spleen, right? So they're gonna be more likely to be sick and more immunocompromised. Alcoholism, so all of those things on your left are your comorbidities. And then if they have a comorbidity, then you're gonna say, all right, I need to add on something else. I need to give them extra coverage because, hey, they may not be able to fight off these bugs as well. So then you see that you're gonna have your beta-lactam plus your macrolide. So, or you can do your doxycycline. Typically what I see is I see the amoxicillin with azithromycin, typically. But I could do my amoxicillin with doxy, right? So this just looks like what we saw up at the top. Now they just kind of pick two of them, essentially, okay? Don't worry about doses. I don't want you to remember doses, all right? So you're gonna pick one of your beta-lactams plus your macrolide, and typically the macrolide that we're gonna be choosing is gonna be our azithromycin most of the time. Also, you have your monotherapy with your fluoroquinolone. I don't see this used a lot because, again, the fluoroquinolones, we have our side effects that come along with them, and it's just the idea of if I have this comorbidity that I'm trying to cover as much as I can, and typically they will put them on 2 agents. But you do see that we have an option to just say, hey, I'm gonna put you on just the fluoroquinolone, all right? Typically, we will treat for 5 days. If they have some of our bigger, more serious bugs like our MRSA or Pseudomonas, we will treat for 7 days. But for the most part, outpatient, we are treating our patients for pneumonia 5 days. We're bringing them back for a follow-up, make sure that everything is clear for them, okay? So, remember your first line for pneumonia is the same thing that you had first line for your acute otitis media, which is amoxicillin. And then if they have a comorbidity, so just think about somebody who is real sick, or diabetes, anything that would make somebody not be able to completely fight off a bug themselves, then we're gonna do our beta-lactam with our macrolide, or we can just do the fluoroquinolone by itself, okay? Looking at our CAP inpatient, further stratified because I can go ahead and put them in the ICU, or I can have them in a non-ICU, right? If I think that they're very severe, they're super sick, they're not being able to breathe well, like they're super struggling, there's different criteria that you will look at and get different scores to decide if you want to admit your patient or not. So when I'm looking at my non-severe, so they're not in the ICU, you see that you have your beta-lactam with that macrolide. So this looks almost like what we were talking about before if they had that comorbidity. So you can pick your ampicillin sulbactam or your ceftriaxone. Remember those two that are in bold. I'm not going to ask you about ceftazine or ceftarolene. So I'll ask you about one of those in the bold. And then with your macrolide, okay? So we had our ACE, azithromycin, erythromycin, or you have your doxy that you can use there. Remember also that you could just do, you have your respiratory fluoroquinolone. Remember that Cipro was not going to fall into that, right, because of that resistance that we talked about. And then in this situation, you can consider, doesn't mean that we're having to treat for our MRSA or our Pseudomonas. Depending on how sick that patient looks, if they look very sick or if we see other comorbidities, we are likely to treat for it, but it's not like you have to treat for it, okay? But now they're in the hospital, so now we're worried about MRSA and Pseudomonas coverage. With our severe, again, looks very similar to what we saw above, right? I'm doing my beta-lactam with my azithromycin, or I still have the same thing, the beta-lactam with one of my respiratory fluoroquinolones. Now I kind of combine those things together, okay? May consider, again, your MRSA or your Pseudomonas coverage, not something that you have to do, right? Here are our summary charts for you. So this has a summary chart that's giving you all of the agents that we kind of talked about that will cover your Pseudomonas. So this is the review slide for you to say, hey, what do I have if I have Pseudomonas that can cover that bug? All right? And then I think I have another one for you whenever we do MRSA. This, don't worry about this. Not asking that. Same thing. This was talking about like making sure that they're getting vaccinated. Not asking you that. Same thing with this. This is another one. So when you're looking at your patients, especially whenever they're older, vaccinations are very important. You're gonna probably get a whole little class about that. Most of the time, we're looking at our patients who are over the age of 65. You do have some people who have comorbidities who are likely and more susceptible to end up getting pneumonia, and we will also vaccinate those people even though they're younger, okay? So just understand, you doing that complete med rec, also look at their vaccinations, make sure they're up to date. They're active, typically we're up to date, but still check it and make sure that they have that documentation, okay? All right. When we're talking about infective endocarditis, so remember this was what we were talking about, like they're having some type of bug or issue build up, not good, on their heart. And it can cause a lot of problems, and if we don't treat it, it can lead to death. So this is just a definition. I don't need you to remember risk factors, any of that stuff, just remember endocarditis. When we're looking at this, thinking about endocarditis and what happens if they start to have these essentially like plaques or this vegetation that will build up on that area of the heart that they have found that they like. And so we have to use our antibiotics for a longer period of time to try to combat what they're doing, right? We're trying to break up something that they've already formed, okay? So most of the time, we're at a minimum of 4 to 6 weeks for treatment. Some people's treatment can go over 6 weeks, okay, depending on if they're not clearing that bacteria enough with our drugs that we're giving them. So the big thing that I want you to know and what I want you to remember is that when we go through these next couple of slides, your treatment duration is going to be 4 to 6 weeks, okay? Now, we talked about this when we were going through some of our medications and like, hey, what are we trying to cover? So when you're looking here, when we're looking here, we have endocarditis that was caused by strep, okay? So make sure that you're following that this is your endocarditis for strep, okay? These are all of the different bugs that you could potentially see. I'm not gonna ask you about the bug. I'm gonna say, hey, they have endocarditis and it was caused by, you're gonna see strep or you're gonna see staph. That's all I'm worried about for you to remember, okay? So just remember, this one is one that we're gonna talk about a lot, and this one is one that we're gonna talk about a lot, okay? What happened? Was that in y'all's too? About this? Okay, so this, when you're looking, you have our endocarditis, and this is our group, right? We're looking at strep. So this is your Viridian strep, group strep. Here are your drugs of choice, all right? Pin-G-K, ceftriaxone, Pin-G-K, or ceftriaxone with the gentamicin. The reason why we're doing that gentamicin is to try to help us get like a start to break up those plaques if they're really bad, okay? So that's where you see the gentamicin, it falls off after the 2 weeks. And then you have, if somebody cannot tolerate any of your other medications that we looked at, your Pin-G, your ceftriaxone, then of course we can go to our IV bank, which should cover it, okay? So when you're looking at this, this is saying a native valve. So if they have like their own, they haven't had any type of heart surgery, they haven't had any type of valve replacement. So native valve, and it's susceptible to penicillin. So we tested it, we saw that, oh, okay, this one is sensitive to penicillin. So therefore I can use any of my drugs that I'm looking at right here, right? Because penicillin, this is a cephalosporin, but penicillin. So I can use my beta-lactams, I'm okay. This one is saying, hey, I'm resistant to penicillin, right? So if I'm resistant to penicillin, it's gonna be kind of hard for me to use just penicillin by itself because I have some resistance going on that I may not be able to overcome. So that's why you see your ceftriaxone, if it's susceptible, because sometimes things that are susceptible or resistant to one beta-lactam may be resistant to another, so that's why it has if susceptible. And then you see here, the same thing what we were talking about was 2 weeks before. Now we're treating them for a longer period of time, seeing if we can overcome the potential resistance. Most of the time, we're gonna go to bank, okay? So all I want you to look at, and I'm just going through this so you can kind of understand the difference, Prosthetic valve, I don't have my native valves. I had some type of valve replacement. Bugs like to stick to things that are not native to your body more. So think about like if I had some type of foreign material, my body is gonna attack it more, right? So therefore, when you're seeing your prosthetic valves, I have to now treat them for longer. So that's why you see the difference between the 6 weeks versus our 4. So what I want you to know from here is, hey, this is my bug, I'm looking at strep endocarditis. I have these drugs as my option, and it's gonna be 4 to 6 weeks. That's all I need you to know. 6 weeks is gonna be if they have a prosthetic valve, and then your 4 weeks, bless you. And I'm gonna leave it at 4 weeks, I'm not gonna look at the one thing that says 2 weeks. Your 4 weeks is gonna be the one that you are looking at where I have my native valve, okay? So 4 or 6 weeks. 6 weeks is for which valve? Prosthetic. And we're looking at which bug? Strep, okay? So there are your options. Now, looking at this, I'm now looking at staph, okay? So this is my staph treatment. Now I have to make sure that we are methicillin sensitive, right? If you are not methicillin sensitive, then that means that I can't use my anti-staph penicillins that I have. So when I'm looking at that, you see I can use my nafcillin or my oxacillin, and I have cefazolin, okay? You see with this, remember staph is king. Staph is a bad bug, right? So this is automatically getting 6 weeks. So there's no like, oh, we're gonna be nice. We're trying to take staph out. Big, big bug. And then this goes with the same things that we kept talking about with our drugs that we have. So nafcillin, oxacillin, and then if they have a allergy and it wasn't anaphylaxis, okay, so like our non-severe, so just like that hypersensitivity reaction, then I have my cefazolin. If I'm resistant, then I have my vanc or my daptomycin. So resistant is essentially saying, like if it's MRSA, okay? So if I'm resistant, methicillin resistant, then I can use my vanc or my daptomycin. Okay? All I need you to remember, all of these treatments for this one, 6 weeks. Because staph is a big bug that I need to fight. Now, my prosthetic. The difference that you see here, we see several different drugs, right, or the same drugs. So my nafcillin or my oxacillin, cefazolin, and then what you see here now is like I'm saying, oh, give them rifampin or gentamicin, because what we saw is that, again, like I told you, it can help break up that vegetation, right? I'm a prosthetic valve, my bugs are stuck to it because it's a foreign object, and it's easy for it to make those vegetation, those thick plaques. So I use my gentamicin and my rifampin for that first 2 weeks to kind of break it up and make it easier for my antibiotic to get in there and do its job. Okay? So again, this one is at least 6 weeks. Sometimes, depending on how bad it is, we go over that 6 weeks. Okay? So, same drugs. You have your vanc here again, and then you have your nafcillin, oxacillin. Big difference that I want you to know is that you're giving them that rifampin and the gentamicin to help for those first 2 weeks, like break up that vegetation because it's a prosthetic valve. So, keywords: prosthetic, staph. If I'm susceptible, meaning I'm not resistant, then I have my parts of nod right outside of dicloxacillin. If I'm allergic, I have cefazolin, and then I'm adding my rifampin or my gentamicin, but just for 2 weeks. And then if I am resistant, so think about your MRSA options that you have, then I'm usually using my vanc, and I'm gonna still do that first 2 weeks with my rifampin and my gentamicin to help break up those plaques because I'm a prosthetic valve. At least 6 weeks. Sometimes we go longer with these patients who have prosthetic valves. Very sticky, yes.
You said both the rifampin and gentamicin?
No, sorry, one or the other. Those are your options that you have. You can use, typically I see them pick one. If I ask you on the exam, I will have one there.
So one or the other?
Yeah. Yes.
So would rifampin be for the whole 6 weeks?
No, 2. It would still be 2. It's the way that it's written, it would still be 2. I think it was just like when they made them, we copied and pasted it and just put it there. It would still be for 2. I will rewrite this slide and I will post it, because I see the post. I will rewrite the slide and I will post this one
Just
again.
my thing.
No, oh my gosh.
You're not
Yeah, somebody had don't say that.
you're not the first one to say that to me.
Well, because I'm trying to read y'all's body language. I will rewrite this and I'm gonna post this up today by the end of the day. Somebody had their hand up over here. Yes.
And then so from like just the native val, you're still, the way you would treat native val and prosthetic val are still the same, with the caveat that like now you need your,
The gen and the rifampin.
yeah.
And the duration. The duration may increase. It's at least 6 weeks. Sometimes we can get away with 6 weeks, sometimes we can go longer than 6 weeks. So it's saying like at least 6 weeks. So that's the difference between this one, where you're saying 4, and this one is saying at least 6 weeks. Y'all will get a whole bigger thing on this. If I ask anything on them, they're very basic on the questions that I'm asking. Yes,
Ma'am,
yes.
is rifampin a TB drug?
Say it again.
TB drug?
What? Yeah, we're gonna talk about it. Yeah.
That's-
We'll talk about this, like, the rifampin, we're gonna talk about a whole lot. We're talking about it probably today, I think.
Sounds good.
Yes,
Order.
yes. That was funny. Okay, your skin and soft tissue. We kept saying SSTI. This is what you kept seeing as SSTI. Several different, I guess, levels of severity when we're talking about skin and soft tissue infections. So the way that we treat them will be a little bit different. So here, I have my non-purulent and purulent. Essentially what I'm saying is, this has no pus and this has pus. Like if I cut it open, something is going to come out, whereas this, the only thing that's coming out is probably some blood, okay? So non-purulent versus your purulent. Then I can classify and say, okay, severe, moderate, mild. All I want you guys to remember from these are gonna be the very first things that are listed on here. When we talk about our treatment for them, I don't need you to remember like, oh, I have all of these different options. When you see your CNS, most of the time we are going to try to get our cultures, remember, before we do any antibiotics. Like, I don't want to have antibiotic in my culture because it's probably going to start killing our bug. Okay, so that's the only thing I don't really love about this picture. Maybe they're saying that they got the results back at this point and then they defined. So when you're looking at your severe, you see that you have your vanc and zosine. Remember I was telling you a lot of the times when you're doing empiric treatment, we don't know what's going on. We typically will use those together because they're going to cover we're casting a huge net when we do our vanc and zosine. They will be in the hospital and these are going to be their IV meds that they're receiving. We'll run both of these bags for them. When we're looking at our moderate, again, I have different options available. Just remember your penicillin. When we're looking at our mild, this means I don't have to have them hospitalized, right? I'm not running this via IV. I can see them and send them home. So with this one, I'm just saying, okay, let me give them some PNBK. You're gonna see that we saw all of these drugs. This was in our clinical use. So that's why I'm saying, like, you've seen these before. Most people try to look at this chart and they get overwhelmed instead of just looking at what we went over in part 1 and part 2 and remembering, hey, this has clinical uses. So this is a summary for it. Just look at, if you want to look at this, and if it says clinical use under clinical use on the slide, you should see it here, listed here as well. That is the little caveat that I will give about this. If you see it on your slide and it says clinical use, this is like a summary of that, okay? But it's not telling you the severity, and I'm probably not gonna ask y'all that way. If I make a question on this, I'm gonna direct you. You will know what I'm asking for. When you're looking at your purulent, IND means that you're gonna cut, right? Because I told you, like, if you cut for this, something is gonna come out. There's like pus in there, right? So you're gonna cut, drain that incision, you're making your incision, you're gonna drain it, you're gonna get your culture, and then you're still doing your empiric treatment. because we don't know what's causing it. So that's where you see your bank, you have all of your different options. All of these, for the most part, we can get very good coverage, very broad spectrum. Some of them are covering that MRSA. We have that MRSA coverage as well. And then down here, I don't need you to worry about the defined therapy. That's essentially saying, after you got your culture back, it's gonna let you define your therapy. Not worried about that. And then looking here at your mild, your moderate, again, because there is some, it's purulent, I need to make sure that I drain it, I get my culture, and then I'm still doing empiric treatment, so I can do my Bactrim or my Doxy. In these situations, we can do oral options, right, because these have oral formulations. And then if it's defined, I'm like, oh, okay, yep, I now know what my bug is, these are my options. I want you to worry about empiric for up here, okay? Here is your summary chart for all of the drugs that we talked about that cover our MRSA, okay? Make sure that you're looking at the pseudomonal slide that we had that summarized everything for you, and then your MRSA slide that has everything kind of summarized for you, okay? Because these are our two big ones that were in the red box that in anaerobic coverage. But these were two of our big ones that we were looking at. So this is how I would kind of see, hey, we went over a lot of drugs. What's covering those bigger bugs in my red box? This is how I would make them. I haven't done all of them for you, but I'm trying to start with the bigger ones. All right, GIGU. This is more so looking at UTIs. When we're talking about UTIs, we typically are going to have bugs, right? That's our colonization that we're talking about. When we're looking at a UTI, typically it's what do I want to say? Only in or localized in our lower parts, okay, in our urethra. When we get to pyelonephritis, this is what we were talking about when we were saying, hey, if the drug does not penetrate there, I cannot give it. So that's why we said if something concentrates in the urine, it has to be one of our uncomplicated UTIs that's in the urethra. It has not traveled up to the kidneys and caused pyelonephritis. And you will hear sometimes people say them as the same thing, and then that's wrong because you don't know what you're treating, okay? Because this will knock out some of your meds that you're able to choose versus if you have a UTI and it's just consolidated or confined to your urethra, okay? So that's the difference between these words that we've been seeing on the slides of like, hey, complicated, uncomplicated. Further looking at that, I am going to tell you if it is complicated or not complicated, okay? So I don't need you to remember that. I'm going to tell you if it is cystitis versus pyelonephritis. You just need to know what drug you're going to use for it. Now, this will vary depending on this male sex. Some people say that if a male has a UTI, it is automatically classified as complicated. Some say that it is not. So depending on what your ID department has decided at your MTF, that is what you go with, okay? Some will say automatically a man got a UTI, it's complicated, we're gonna treat it in a complicated manner, whereas if a female has one, they're gonna say, oh, it's uncomplicated, unless she's. So, uncomplicated cystitis, and this is exactly how I would word this if you had this, right? Because we're not diagnosing. So, UTI, uncomplicated cystitis, here are all of my medications that I have available. We've already talked about a lot of these meds. Looking at your fluoroquinolone or your beta-lactam, you can use it, either of those also. Remember we had those, but our main ones were what we were looking at that were specifically focusing on UTI. Remember your antibiogram is going to definitely come into play with these drugs, right? Because when I'm looking at my antibiogram, if I have a lot of resistance in my area to this or to a fluoroquinolone, all right, now I have to go somewhere else. So your antibiogram is very, very important for you to look at. On the exam, if I give you a question, I'm just going to give you one of these. There will be a reason maybe why somebody can't use it. I can't give you nitro and Bactrim without giving you an antibiogram and telling you to pick it, is what I'm saying. So there will only be one right choice if you see something like this. Your uncomplicated pyelonephritis, so remember this has gone up further, right? So this is not consolidated or localized in just that urethra area in the lower tract. this has now gone up. So this is pyelonephritis. Now you see your fluoroquinolone, your Bactrim, and then you can also have the beta-lactam. Again, depending on if you're going to use that beta-lactam or your fluoroquinolone will depend on the antibiogram. If there's resistance to fluoroquinolone, you're going to typically end up using your, you'll go to your Bactrim and vice versa. If I'm resistant to my Bactrim in my area, then I will use my fluoroquinolone, okay? If I have no option to use either of them, then I have my beta-lactam. So I just want you to remember what you're using. I don't need you to remember your, on this one, I want you to remember what you're using. This one, we already talked about these, so I want you to know that you can use these as your alternatives for your UTIs. Your pregnant women. So we talked about our drugs and we were saying, hey, if they're pregnant, they may or may not be able to use these drugs. So this is what we're looking at to say, even if they are asymptomatic, meaning they don't have any symptoms, if they're pregnant, we're treating them, okay? So you have your ceftriaxone, your augmentin, and your fosfomycin. We already talked about these on the slide and we're like, hey, this is safe in pregnancy for us to use. Remember when we were talking about our penicillins, we said, oh, those are safe to use. Our ceftriaxone, this was safe to use. Our fosfomycin, this was one of the ones that we definitely used in our pregnant women, and they only had to do that one dose, okay? So if you see somebody who has a UTI and they are pregnant, you can't say, oh, I'm gonna use nitro. Oh, I have to pick one of these medications for my pregnant person who has a UTI, okay? And this is just telling you all the things that you are avoiding in your pregnant patient, right? So this is what you need to remember. These are not your options that you have available for them. This is just, again, giving you several different medications that we can use for the treatment of our pyelonephritis in our pregnant patient. So now, again, we talked about our UTI on the previous slide. This is looking at pyelonephritis in the person who's pregnant. So you see you have several of your cephs, you have aztreonam, and then you have your ampingent. And those are given together. Don't remember doses. If it's very, very severe, or if you see that your person is having incomplete emptying whenever they're using the restroom, this is kind of where we're likely, they are going to be hospitalized. And so here you have your Zosyn or your Pip-Tazo, and then your meropenem, ertapenem, doripenem. Usually those top three are the ones that we're using. So just remember, for your pyelonephritis, we're looking at our cephs, we have our ampingent that we can use. And then if it's very, very bad, IV medications are the options that we're gonna use. So your Pip-Tazo, and then you have your meropenem and your ertapenem, typically the ones that we're gonna look at. In our UTIs, talking about the fact of if Pseudomonas is going to be a part of the infection that they have, just pick an agent that you know can cover Pseudomonas. Not something that we typically see. Actually, I don't think I have seen it treated with someone having Pseudomonas, but doesn't mean that it is not something that can happen, okay? So you see the pyelonephritis and you're complicated, that's what this little c is. So your complicated UTI is caused by you having like a very resistant or hard to treat Pseudomonas. These are our options that they have. They're going to be hospitalized. Typically what we do when somebody has a UTI, you will call them to follow up with them. You're supposed to after they leave the ER to say, hey, did that infection clear? Because if it didn't, then maybe I gave you a wrong drug, or maybe your bug, not necessarily the wrong drug, maybe your bug is resistant to that drug that I gave you, okay? So then we would either prescribe them something else, or typically we prescribe something else, and then if that doesn't work, we bring them back in, and then they can end up on some of these. So ceftolozine, tazobactam, remember these are our really big guns that we talked about. Your ceftazidime with your avibactam. Your avibactam is another beta-lactamase inhibitor, okay? And then your imipenem, celastin, this one was the one that was helping our, cilastatin was helping our imipenem last longer so that it didn't get degraded because it caused that nephrotoxicity. So this, remember, is not a beta-lactamase inhibitor. And then your cefidorocol is another antibiotic that we don't use very, very often, okay? When you look at your urosepsis, essentially this is saying that now it has now been spread throughout your body, it's going through your blood. Very serious condition, we will have them in the hospital, aztreonam, plus or minus the gentamicin. Typically, they will start with other meds first, but this is just an option that you have for your urosepsis. Chlamydia. So, when you're doing this, we test pregnant women all the time to make sure that they don't have STIs, STDs, because when they give birth, then they can pass that on to the baby because the baby has to go through that birth canal, right? So we make sure that we're screening and that people are being protected. So all I need you to remember is for chlamydia, we have our doxy. The other conversation that you have to have with your patient. Some people may use sex toys or other things, right? The conversation needs to be that if you're treating them, that they need to have a conversation with their partner, because sometimes you're gonna need to have that partner come in and get treated because we're gonna assume that they also have the infection. And then with the toys, what sometimes happens is people may not clean those and then they continue to reuse them and then they continue to reinfect themselves and trying to figure out what's going on, okay? So that is also another thing that needs to happen, all right? So you're treating both people. That's the conversation that they have to have if they're worried. That's where it came from, not your problem. But your problem is to make sure that we contain as much as we can and inform them that their partner needs to be treated also, okay? So chlamydia, doxy, that's all I need you to know. And then C. diff, we talked about C. diff already. Fidaxomicin was our main one that we wanted to use, and then we talked about bank, and then you see how you can keep going down and fecal transplant, all the other stuff that we talked about. So your big thing here is C. diff, fidaxomicin, and then I have bank as my alternative. I will repost, let me make sure I stay on that side. I will repost this one and clarify it, and then let's take our 10, so come back at 11:01, and we'll start our next lecture.
No, they look. I mean, yes and no, they did. Like, they weren't as like positive, but like it's still interesting that people came out together. I don't know how my brother would say it was as helpful as it could have. Also because I wasn't expecting that.
She acted like she already talked to me about it.
Yeah.
So,
I mean, probably.
I mean, that's what happens. I find out stuff that we're doing. And she's like, yeah, I didn't know. No? Maybe they did. You can touch anything you want. I don't care. Let's just go.
In this order.
So if you love like Cash App self-Vendo, if you in one transaction you $600 and now the IRS makes you clear So I know Cash App instantly, if you ask for it, so like it processes after a couple days, it does it, but if you ask immediately, it makes no sense. Which is funny because I was reading on posts about like landlords, like they allow like Cash App. But so like, okay, so it's due on the first. But then I saw someone selling cease and desist, like, oh,
That's all we do.
Cash, yes, I think okay.
No problem.
The air, yeah. There's some guys who actually like hospital, which is all like frozen. It's like a big y'all seen dude.
Alright, sorry, my computer is not working. Oh, if we call it, then y'all won't get a day back that I'm working for.
It'll be a whole. I guess you're watching. I'm watching one dude.
Okay. I wanna go back real quick because I said something and I said something that wasn't. I tell y'all when I make a mistake and I was thinking about it and I made a mistake. Oh my gosh. So on this is, just use this as a summary slide, okay? I don't wanna tell you guys to just remember the first one because there are several PowerPoints that we have that have the clinical uses on them, and you will see that they're telling you to use them for SSTIs. The classification of them, purulent versus not purulent, I'm not gonna tell you that way. I'm gonna tell you they have an SSTI. What are you using? And it will be one correct answer, okay? So that's for that one. This, so when you're looking at this is looking at your drugs that you can use for your pregnant patient who just has cystitis, right? This is just cystitis. These are oral options that you have. Your patient does not need to be in the hospital. So this one, because it's not bolded, I guess it made it a little bit more difficult. So this is just your regular cystitis. This is your parenteral and your pyelo for your pregnant patient. What I'm going to do on this one is that I'm going to talk to the ID doctor, or now I'll also go over here and talk to somebody that I know that deals with this a lot. And what I'm gonna ask them is, what are the top two? And I will just narrow it down to two for you guys to remember, and I will repost this instead of y'all trying to remember all of these, because it's a lot of them. So I will put 1 and 2, okay? So The next, clap, 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 I don't need you to clap. I'm trying to make this to where you're learning something, because y'all learning third, fourth, fifth line of things is like useless. Somebody say stupid. Okay, the next thing, players mess up too. Let me tell y'all where I messed up. Okay, so when we're looking at this, the question, I don't know why I like panic when I had a question, because y'all ask me for it all the time. So your gentamicin. Your gentamicin is the one that's always gonna stay for 2 weeks, okay? It's gonna be on for 2 weeks. When we look at our prosthetic, your rifampin is 6 weeks. I think it'll be better to write it this way. Your rifampin is 6 weeks and your gentamicin is for 2 weeks, and you're keeping them, I don't know how to say it that way. You're keeping them both, they're both on, I guess if that makes sense. But one is for the entire duration and the other one is only for the 2 week duration. So I'll try to I'm gonna post this slide, but I think just writing it this way is better than trying to have it how it currently was with just the note here. So 6 weeks and then 2 weeks, and then this fall your gent is gonna fall off. So the same thing.
The first 2 weeks, both drugs concurrently,
Yes.
and then the next 4 weeks, the rifampin keeps going.
The rifampin will keep going with your other treatment, and then your gent fell off. Okay, so all of them, and then gentamicin is off after the first 2 weeks. Okay,
Ma'am, just to clarify, I thought you said we could use either rifampin or
I know, that's why I said players mess up too.
So we can do all 3 drugs.
Yes, and then, but the time that you're using them varies, right? So that's why I went and I wrote it like this, because this registers better. So, yes, gentamicin always will be on only for 2 weeks, and then the rifampin for your prosthetic stays on for the full 6 week treatment.
Just to clarify again, ma'am, it's rifampin or gentamicin?
And,
Okay.
that's what, yeah, but the duration of the and is also different. 6 weeks for
6
one,
weeks.
and then 2 weeks for the other one. The gent will drop off after the 2 weeks. Okay? I'm not gonna get that super nitty gritty and say how long is one supposed to be on there. I'll just put them both if they're an answer choice, but I want to make sure that this makes sense for when you see it again.
In
Yeah.
the first 2 weeks for the.
First 2 weeks for gentamicin, 6 weeks for the rifampin. Y'all stop laughing, don't make me laugh. Cause I want y'all to feel comfortable to ask questions, okay? We can't laugh at each other for asking questions. Okay, let's open up our antimicrobial agents. So this is a fun lecture. This is a quick lecture. It has a lot of background that we're gonna talk about, but not really talk about, so that you know what we're talking about, and then we're gonna go on to our drugs. I'm gonna super simplify the drugs and hopefully not oversimplify it, okay? Uh-oh, here we go. ELOs are listed here. Okay, your mycobacterium. Now I know what it means, and y'all didn't even do it. That was sweet. I'm not accepting that. So, when we talk about mycobacteria, does anybody remember how your mycobacterium stains? Like what, you're using it, but remember we say it's gram stain neutral? Like it's not really picking up any of our colors. Does it grow slow or fast?
Very slowly.
Very slow. So a lot of the times with our patients who are gonna be infected with mycobacteria, we are gonna be treating them for a minute, and sometimes by the time that they're showing symptoms, we might be a little bit behind the 8 ball, okay? So essentially what this is saying is what we just talked about. It's slow, we have a lot of resistance that can occur with these bugs. This first part is not on your test. This is for us to know what we're talking about. I will tell you when we get to test material. When we're talking about TB, okay, tuberculosis is what we call TB. Essentially what happens is people are out there, they're sneezing and coughing and living their best life, and they're passing on those aerosol droplets that have the tuberculosis in it, and then other people inhale it, and then we have the infections, okay? So that is essentially what is happening. All I need you to know from here is that that's how it is transmitted. Depending on the amount of particles that is inhaled, that is, or how virulent they are, that will depend on how symptomatic or how critical your patient may be, okay? Over time, what you can see is that somebody can be in a latent stage, and we can treat them when they're in the latent stage, or they can have active. When they have active, most of the time those patients are going to be symptomatic. You're going to know that they are infected. So when we're looking at this, just understand that most of your people, after they have that primary infection, after they presented with that primary infection, they'll remain symptomatic, they'll clear that infection, or asymptomatic, they'll clear that infection, and then sometimes you can have where people have reactivation of their tuberculosis, okay? So that's what we're worried about. We're worried about our latent people because sometimes they don't realize, like, hey, I'm infected. My asymptomatic people are the worst ones because they don't have any clue, right? It's the same thing if you think about, like, STDs and stuff. If somebody is asymptomatic, they can go and have sex with somebody else and they don't even know that they've passed something on. This is the same thing. Looking at your latent versus your active, I will tell you, this is just for completeness, for you to know what the symptoms are, how people look, if they even have symptoms, okay? So I will tell you if your patient has latent or active TB. When we're looking at our people who get tested, essentially what we're thinking about is like, hey, if somebody is severely immunocompromised, so the big population that we like to think about here are patients who have AIDS. We also think about our healthcare workers, right? Everybody in this room, because we may be in contact with somebody who has TB. Typically they're sick, they're gonna come and they're gonna see you. They want you to treat them. So we also get tested quite a bit as well. So just make sure that you're understanding, like, there's a lot of testing that goes on, especially with us, and why we're required to get it. Diagnosis, there's several different things, y'all are gonna learn this, but you do like a sputum catch, and then we send it to the lab. We also do chest x-rays to kind of make sure, hey, did you clear that infection that you had? Where are you with this treatment? Are you responding properly to your treatment? So these are different things that we can diagnose with, and we can also check to make sure that our patient has cleared that infection with some of these things also. Your skin test, this is that PPD that we do, where they inject us and then we come back in a couple of days and then they measure it and they're trying to see like if we have active TB or not. The more immunocompromised you are, so let's say you have a poor immune system, the smaller they're allowed to have growth in that raised area that they're measuring, okay? We are very, very cautious with those patients. All right, this is where your test starts, okay? So, when we look at how we're gonna treat our patient, the first thing that you need to realize is, are they active or are they latent? Because your active treatment is going to be different than your latent treatment, okay? So that is your first step when you're studying for this. Write active TB, you'll write down your drugs, write latent TB, and then you'll write down your drugs, okay? And then when we're going through this, you're gonna write down, hey, what are the important side effects that I'm typically seeing? What am I worried about? What would make me not use this drug in this patient, okay? So when we're looking at our duration of treatment, we have two different options. We have a short course, which is usually 4 months, and then we have a long course, which can be anywhere between 6 to 9 months. When we're using this long regimen, while you see the 6 to 9, depending on if you get that chest x-ray back and if it's not cleared, then we're gonna extend their treatment, right? Because we haven't treated their infection. We like to use short course, but you can use either of these options in your patient. Of course, making sure that my bug is susceptible to my drug that I have to use for my patient. What are my comorbidities? Because in some of my patients, like an HIV positive patient, there may be drugs that interact with my HIV meds that I'm using, okay? So I might be a little bit worried about that. So I have to take these things into consideration. So there's several different ways that we need to manage that. Also, we have what's called direct observed therapy, that's where you're making sure that they're actually like taking the pill. They have to come in to you and take the pill in front of your face, and you're like, oh, cheeks, you're checking everything to make sure they took it, right? So when you're looking at your dot, we use this in our HIV patients. We also use this in patients who keep not being adherent to the medication, okay? If they keep getting off, right, and we're not treating them, they're not clearing that infection, sometimes we'll say, okay, you just earned yourself some dot and you created extra work for me. Now we have to make sure that you're taking your meds every day. Health department also helps a lot with this. And the ID department here will help us a lot. QT prolongation is, again, you're gonna see this in some of our drugs. Remember we were talking about with our antibiotics, we have some of them that cause QT prolongation. So we definitely wanna make sure that we're watching out for our patients who have this, because we're gonna have and talk about some of our drugs that can cause QT prolongation. And then your interactions, like I just talked about. So your patients who are HIV positive, a lot of times what we put on our backbone for our active TB has rifampin in it. But our HIV patients, that interacts with a lot of the medications that you would take for if you have HIV. So we will try to use our rifabutin instead of using our rifampin, okay? So in our HIV positive patients, instead of us using our rifampin, we like to use rifabutin, okay? What other drug did we talk about? Well, I'll just tell y'all. Remember when we were talking about our fluoroquinolones, that was one of our drugs that we said, hey, we need to watch out for QT prolongation. So kind of start trying to put things together and remembering, what am I looking for? What are the big things that I'm worried about? And then looking at this, if you have your QT interval prolonging drugs that somebody else is taking in addition to your other meds, we may be worried about those things. And when we see this 4-month Moxie regimen not ideal, it'll make more sense whenever we get to the treatment regimen. So this is our backbone that I want you to remember when we're talking about TB. So you have right, okay? Remember right. So you can pick one of your rifamycins. Typically, we like rifampin, isoniazid, pyrazinamide, ethambutol, and then I have moxifloxacin if I'm going to do my 4-month regimen, which we're gonna see in a minute. So when you're looking at this, you're saying, hey, if I have my moxifloxacin on, you're not gonna see me with my ethambutol. So that's why I put this here. Your moxie is replacing your ethambutol in that right. So instead of having right, you have ripum for your short course, for your 4-month. You're going faster. So you're ripping right through, ripum. Huh? Or that. Sure. I just like to know that I'm going faster, so I know the difference between my 4-month and my 6 to 9 month. However you like to remember stuff, up to y'all, okay? So that is the difference that you see here, okay? So my rifamycin, isoniazid, pyrazinamide, ethambutol. And if I want to do a short course, then I'm going to replace that ethambutol and I'm going to put my moxifloxacin in, okay? So they're on 4 medications. Anytime that you see isoniazid, and we'll talk about this later, your patient should always have B6 on as well, okay? So if they have isoniazid, you should see plus B6. You should be prescribing that. And the reason why that is, it will help decrease the side effects that they experience whenever they're taking the isoniazid, okay? So isoniazid, B6. So this is looking at what your 4-month trial looks like, and this is them being on those 4 meds for 4 months versus being on 4 meds for 6 to 9 months, okay? It is just as effective, so it's not like one is better than the other one. Just using like as a practitioner, your knowledge and knowing your patient, sometimes it's a lot easier for us to just get through the 4 months versus having someone on meds for 6 to 9 months, right? They're more likely to be adherent to it. So when you're looking at your 4-month, you see here instead of our rifampin, which we are typically using, right, in our 6 to 9 months, you have rifapentine, isoniazid. What am I supposed to add if I ever see my moxie, because remember what drug did this replace? Starting with E? Ethambutol, right? So instead of using my rifampin, which we love, good drug, I'm now saying I need to hurry up and rip through this. So I'm using my rifapentine, and then I have my moxie, okay? So that is the difference. This is what I need you to know from this slide. There's lots of other things. If you want to read into more detail, you can. I am expecting for you to say, 4-month, this, right? I have my rifapentine, my isoniazid, we know that we have to have B6, my pyrazinamide, and my moxifloxacin instead of my ethambutol. Okay? Yes?
Are HIV patients able to do glucose while not pregnant, or are they
We're going to talk about it. We're getting there. The other thing I want you to remember is this comment, right? That one is not better than the other. What makes you pick one is you knowing your patient, right? And also, are there any things that are going to say, hey, I cannot choose this for this patient. I can't use this drug for this patient. If there's anything that makes, if there is a contraindication, or if there's a condition or a disease state in which I cannot use that drug, that is what is going to shape which treatment option you're using for your patient, okay? So, this is what your 6 to 9 month regimen looks like. I want you to pay attention over here to these words. All of these different options as to what you have, there are several different ways for you to take the medication, right? There are several different combinations because I had 4 different rifamycins that I could have picked, 3 or 4 different rifamycins that I could have picked from, okay? So I don't need you to remember every single combination, the duration, I don't need you to remember all of that. I just want you to remember that we have, for our 6 to 9, we have right. That's typically what we're using for our 6 to 9 months is right, okay? What I want you to pay attention to here are these words that are listed. So when you're looking at this, understand that the more doses a patient has, the better or more effective that treatment is thought to be. What that means is we have some of these different things. We're like, hey, I'm taking it 2 times a week. Oh, I'm taking it 3 times a week. Versus the fact that somebody is taking something every single day. When you take something every single day, you're more likely to be more adherent. You're more likely to get more of that drug into your body and clear that infection. So that kind of should make sense, right? As I take more doses, I am now more effective. Okay? I don't need y'all to try to go through and remember this. People try to remember this and it is a waste of your time. You're going to look this up and most of the time IG is going to probably be handling these patients because they're very sick and they don't want us to transmit any infectious disease, okay? So, but if you are the one who discovers, we're talking about 6 to 9 months, what am I using, Ripam or Right? Right, okay? Am I 4-month? Ripam, okay? What is my R? What is my drug for my 4-month for my R? Rifapentine. Yes, okay, so remember this for your 4-month. If I was doing my 6 to 9, I could use any of these. Okay? All right. When you're looking at this slide again, just remember the bold, the more doses they have, the better. And then understanding also that the extended, so how they get to stop the 9 months is like they get to that 6-month period. And then they were like, okay, let's do another chest x-ray. Let's get some more labs. Let's see if they're still showing any signs of infection, or if we see that they had cavitation when we diagnose them, we'll usually put them on a longer treatment dose, okay, a longer duration, longer continuation phase. Active TB in our patients who are pregnant. What I want to tell you about this is that we are more concerned at that point with the population, right? And that pregnant woman with having active TB and us not treating her. So when we look at this, we do initiate treatment. That's all I want you to know. I don't want you to go through all these drugs we're not even going to talk about. Okay? If they're pregnant and they have active TB, you're going to treat. Not you, because we're going to refer to it. We treat them. When we're looking at our breastfeeding women, make sure that they understand that, again, we need to treat them Yes, it does go through that breast milk, but not in quantities where we're worried about the child. Okay? And we already talked about if I have a sonazid, I need P6. Okay, this is now my latent. I don't have symptoms. I am not symptomatic. Okay? You're active, they're typically symptomatic. So when you're looking at this, here are your different meds that you have that are available. What you see here, and when we're looking at this, we have several different durations, okay? So you have 3-month treatments, you have 4-month treatments, 9-month treatments. I'm not gonna specifically expect for you to remember the duration, right? But what I want you to understand is that this treatment is gonna take them a while, right? At the bare minimum, I have 3 to 9 months that I'm gonna be on the medication, okay? So remember the range of 3 to 9 months. Also, what you see is I have my preferred drugs that I am using. I don't want to use any med by itself because I can increase resistance by just using one medication. So that's why you don't see that your isoniazid is as preferred. You can use your isoniazid with your B6, and then you'll have your rifapentine. You can have rifampin by itself, which is like our workhorse when we're talking about TB. And then you have your isoniazid with your rifampin. I need you to remember what your preferred options are and understand that you're typically taking these for 3 to 4 months. You only see that long duration that's up to 9 months because you have one drug by itself trying to do all of the work. So it's gonna take longer, right? So typically, I'm looking at 3 to 4 months of treatment. I have longer treatment in my rifampin because it's just that drug by itself versus me having 2 drugs work together where I have 3 months. Okay? I have one workhorse, it's gonna take me a little bit longer. Right? No doses, none of this, frequency, none of that, don't need you to know any of it, okay? Just, I'm in latent, and here are my preferred options that I have. Typically 3 months, but if I'm using my rifampin by itself, then I have 4. Okay. Pregnancy. When we're looking at this, because they're not symptomatic, we talk about this that most of the time, you will see that we will leave the pregnant mother until after she has the child. So that is why we say the 2 to 3 months postpartum. So when you're looking at latent versus active, your point is that I'm treating my patient who is active, my pregnant person who's active, versus my pregnant person who is latent TB. I'm gonna wait because it's not as critical. And then looking at this, this high risk, don't worry about it, okay? I'm treating my active pregnant person, I'm waiting for most of my latent pregnant people. Okay, missed doses, because it's gonna happen. People aren't gonna take their medication every single day, some do, and we love those people. But then you have lots of people who are like me and they forget and they don't take them every day, bless you. So, if there is missed doses, depending on if those doses are, like how long did we fall below our steady state, like now we missed a dose, so I am kind of outside of my steady state, right? Or did I just miss a dose by 2 hours? Cool, you take that med at that point and you're back on track. Versus if I forgot my med because I went on a cruise for 2 weeks and now I'm coming back, you're gonna have to reinitiate my treatment. So when you see this, it'll be very dramatic. I'm sorry, not when, if you see this. I haven't read y'all's exam, so I don't know what questions I have. If you see this, it would be something very dramatic as what their interruption was. If I told you something that's over 2 weeks, that's a long time, right? So the idea that this drug stayed and it was effective and in its therapeutic window after me missing it for 2-3 weeks a month is very unlikely. So you're gonna have to restart me on my medication. When you see that treatment is delayed or been missed for more than 2 months, then you have to go through the whole process again to make sure that they are not back active again, okay? Make sure that your meds are still working, that they're not, like that bacterial load hasn't increased. And And then I told you, we had our HIV patients who sometimes we'll recommend DOT to, but also if they keep missing doses, we're like, okay, you need to do direct observed therapy. You're gonna come in and I'm gonna watch you take your meds, okay? Okay, looking at our drugs. This is a summary picture showing you where everybody is kind of working. We're also gonna see our MOAs on each one of our slides, all right? So just, we're gonna see all of these. When you're looking at your isoniazid, your ethambutol, we're looking at the wall of that microbacterium. When you're looking at your pyrazinamide, not super clear, but what they're thinking that this works is on the membrane of the bacterium and also the metabolism of it. And then when you look at your rifampin, or your rifamycins, those are typically working on your RNA synthesis. So it starts with the R, that was kind of giving it away as to where it's working, okay? So looking at your rifamycins, for the most part, we like rifampin. If we're doing our 4-month, we like rifapentine. Why do I keep forgetting that R? 4-month is your rifapentine, okay? Remember the difference between the two, because your 4-month does not have rifamycin in it, okay? Rifampin. It has your rifapentine. Y'all, it's too many R's, okay? So you have your rifapentine, not your rifampin. So our mechanism of action, we just talked about this. The big thing that I want you to remember is that it's stopping that RNA synthesis from occurring. Your rifampin is the one that we do use very commonly. For your spectrum, remember microbacterium. That's what we're talking about, right? All these other things I'm not worried about. I'm not going to ask you about that. Remember, microbacteria is what we're treating when we're talking about any of these drugs that we're talking about in this lecture. That's the spectrum that I want you to remember. Looking at your clinical use, you see that if we are active, we're not using this alone. We have 4 drugs when we have active TB, but I had my rifamycin by itself for that 4 months if I were using it for latent treatment. So never am I using this by itself if someone has active TB. I have my 4 drugs on board. If I have latent, you can see sometimes when we have 1 drug, and that's where you saw that 4-month treatment, okay? Looking at our adverse effects that we have listed here. Lots and lots and lots of interactions. If you pay attention as we continue to go through lectures, you're gonna see a lot of interactions. Rifamycin is gonna be on everything. You're gonna see a type of rifamycin. Typically we're referring to rifampin. Birth control, everything. Like it tears up everything, okay? So if you ever see this on board on anybody's, when you're doing your med rec, go to your Lexi drug and type it in and say, let me make sure that my new drugs that I'm also prescribing do not interact with this, okay? So just remember that they're an inducer. That's all I want you to remember. You don't have to remember any drugs or any of that stuff. Know that it induces a lot of other drugs. Hepatotoxicity is another big one, and then that hypersensitivity happens in almost 50% of the people who are taking these drugs. That is a lot, okay? So that is something for you to definitely remember. They kind of get like flu-like symptoms to the medication, and then some of them will also present with that rash that you see listed up there when they have that hypersensitivity reaction, so it just depends. But again, that is a big, big deal when you see stuff that says like 30%, 50%, that's a lot of your patients. Big thing that you need to tell them, because remember when people pee out things or if their poop changes colors, they are worried. You need to let them know because they look at that. So with this, you have a lot of orange-red discoloration of bodily fluids. So this means also like their tears. So people who have contacts, their contacts can get stained. So just make sure that you're letting them know like, hey, if that is happening, just go ahead and switch to glasses while they're taking this med. Their teeth, their dentures, okay? Nobody wants orange-red dentures, that's not what they paid for. So just let them know, hey, this is possible for this to occur while you're taking this medication, right? Looking at our spectrum, we already said that it was covering that microbacteria. Cidal is what we're looking at. Looking at our clinical use, several different clinical uses. Thankfully, we don't see leprosy as much anymore, but we treat it quite aggressively. Sometimes they're taking meds for 6 to 12 months whenever they have leprosy. But you have your MAC here, so your Mycobacterium avium, You see that you have some of our treatment that we talked about with our MRSA, and why we was trying to get in there and break up those plaques with our endocarditis. Prophylactically, so again, with our patients who are latent, we can see that we're using this for TB. And then looking at our drawback, we're not going to use it alone because we have high levels of resistance. And that's most of our drugs when we're talking about TB with this microbacterium. We have high levels of resistance if we're using it by themselves. Looking at our PK, when we're seeing this, a big thing that you're trying to tell your patients and kind of what we were talking about yesterday about, oh, well, I was always told to take stuff with food and all those things. This is another one that we have where we're saying we get a better F, a higher F, if they take it on an empty stomach. So we want them to be real hungry whenever they're taking their rifampin, right? So on an empty stomach. We already talked about the fact that it has good penetration, and then those fluids, kind of think about the fact that they can have any bodily fluid turn that orange-red color. That means that that medication has penetrated to that area. So it can kind of help you remember that. And then looking at your excretion, we're not worried about any type of dose adjustment. So whether that's renal, hepatic, we're typically not worried about that. You don't have to dose adjust for it, which is why we like it. Adverse effects. There are a lot of different things that are specific to just looking at your rifampin, okay? So when you're looking at your thrombocytopenia, that could be very serious to your patient. So labs we're gonna monitor them because remember, we say that we can increase our adverse effects the longer that a patient is on the medication, right? So this is one of those things where we're kind of like, all right, we need to make sure we're getting labs whenever they come in. The hypersensitivity, we talked about that in general with this class. And then your hepatitis. When you look at this, again, when you're doing those labs, you will be able to see their LFTs have started to go up. You're going to be able to monitor that, all right? So hopefully it is something that you catch. And again, if they end up being on treatment for a very long period of time, especially if it gets extended to that 9-month phase, we're more worried about these side effects. They're more pronounced. So LFTs are kind of what we're looking out for. If your person is an alcoholic, most of the time, hopefully your alcoholics will tell you that they're alcoholics. You will see when you get to phase 2 that a lot of times they don't, and they start seizing in the hospital because they're withdrawing. And then you have to order beer from the pharmacy for us to dispense to your patient so that they can stop seizing while they're in the hospital. We have beer in the pharmacy. I was like, what are we doing with this? Why is there beer cans in the trash? And Joint Commission came and we had beer cans in the trash, and I think they thought we were drinking the beer, and it was waste because somebody didn't drink it all. So make sure that you're watching out for your patients who have an increased risk of having any of those issues. Looking at your increased incidence of you having that hepatitis with somebody who is also taking isoniazid. And they're likely taking isoniazid, especially if they are in our right? If they have that active TB, we're likely to see these two medications used together. Does that mean that we cannot prescribe it? No, that means that we're monitoring very closely for it. We're letting our patient know what they're looking for, okay? So that's just a counseling point to say like, hey, you start to see your skin kind of yellowing, or when we come back and we do your lab, we see those LFTs go up, that's what we're looking for. That's why we're looking for it. Our interactions, we already talked about this when we were looking at our overview of the class in itself. So you see that we have the inducer. So we talked about inducers depending on if it's a pro-drug or the regular drug, but most of our drugs, we just talk about regular drugs. You'll see that we're increasing the elimination, right? Our inducer speeds stuff up. It's like that on button, super speed, okay? So therefore, you're going to see a likely treatment failure with a lot of those other medications that they can be taking. We see a lot less of this whenever we have our patient on rifabutin. So that is also why you will see sometimes we will change to a different rifamycin for that reason. So if I'm worried about it inducing a medication, then I'm going to say, hey, instead of me using rifampin, I have rifabutin to use. Pregnancy, don't use it. When I look at my rifabutin, this is the drug that we were just talking about where we said, hey, I have less side effects, right? I have less of that inducing effect. This was the question that was asked earlier. So if I have my HIV patient who is probably going to be on a lot of meds that my rifampin can induce, treatment failure in HIV is horrible, right? Because now I'm not helping them combat that viral load. And then they are gonna quickly progress to having AIDS, okay? Or resistance to their meds. So this is very important for you to make sure that you're remembering, I might wanna do my Rifabutin in my patient who has HIV, okay? Less interactions, therefore my drugs are actually working for HIV, and I have my drugs effectively working for my TB. So that deals with most of this. Looking at your drawbacks. Your drawbacks, your side effects are the same. One that is unique to your Rifabutin is going to be the uveitis that can occur. And essentially, it's like the swelling of the uvea, or the colored portion of somebody's eyes, like they swell, it hurts really, really, really bad. So understanding that that is one of the big side effects that we have of Rifabutin, okay? Looking at our rifapentine, when do we use our rifapentine? Okay. All right. So very similar to all of the other drugs that we've talked about in this class with our very broad overview. We have it in our active, we have it in our latent, and then when we're looking at this, we're not using it alone. So I just want you to remember a big thing with this is which course we were using it in. Looking at our adverse effects, similar to what we talked about with the whole class overview. Interactions, same thing. Inducer, so our least potent inducer when we're talking about this class is going to be your Rifabutin, right? So this one, your Rifabutin, previous slide. Less interactions, HIV patients benefit a lot from this versus you looking at any of your other rifamycins. Same thing that we talked about with our renal dosing. We're not worried about any of that, and we're not using it in our pregnant patients. Isoniazid. So when we talk about this and essentially its role, we're thinking that what it is an analog of our pyridoxine, which is the same thing as B6. So when I was telling you with our isoniazid, anytime you're taking it to help us decrease the side effects that your patients are going to experience, that can help you remember, hey, I'm always going to need that B6. Mechanism, working on the cell wall, that's what I want you to focus on. That same thing with the activity. Remember, we're talking about our mycobacterium. That's what I would ask you about. But if it's you have static and cidal activity. Static, it's bacteria static if it's not in a current growth stage. If it is actively dividing, right, that cell wall is going to be needing to be formed, and therefore you'll see that's when it can work more effectively, and it's going to be cidal in that situation. Resistance, same thing like we talked about before. The more that you use any of these by themselves, the more likely you are to see resistance occur. Looking at our uses, we already saw these, that it was in our active, it was in our latent, so you can remember that very easily. What I want you to look at now is we said, oh, we want to be on an empty stomach, right? When we were talking about our rifampin thing. Now we're looking at this. My isoniazid, I need you to be ingesting something. I need you to eat. I need you to not eat as well. Again, so our absorption is impaired by food. So again, our empty stomach. Looking at your penetration, same thing. We still have good penetration. Big thing with this medication that I wanted us to look at is inhibitor. So we talked about our rifamycins being inducers. This one is an inhibitor. Don't need you to remember exactly which CYP. Just know that it inhibits. And then looking at our pregnancy, this is more detailed than I need you to know, so I'm not going to even ask you about pregnancy for this med, because we're not going to mess with our pregnant patients. All I need you to know about pregnant patients, if it's active, treat them. If it's latent, we can wait. Other than that, we're not messing with it unless it says don't give it. Okay, those are the only ones I want you to know. So the adverse effects we kept talking about, and one of the big ones that you have is going to be that neuropathy that they experience. So whenever they feel that, it's like how we think of our foot or our hand like going to sleep and it has that tingly feeling. That's essentially what they're experiencing. More likely to see this in patients who have different comorbidities. So if they're an alcoholic, if they have diabetes, you're very, very likely to see this. Also malnutrition, and that comes a lot with some of your patients who are alcoholics. A lot of the times they also don't eat and they're malnourished as well. Don't worry about that pregnancy thing, because again, when we use this, it's very off and on. So that's why we are taking that pyridoxine. That's why we take that B6, because we're trying to decrease how much they're feeling that neuropathy. Okay, so this kind of helps offset that adverse effect for them. Your hepatitis and your idiosyncratic hepatotoxicity, this is a big deal if this happens, because this is where we're trying to, this can shut everything down. So again, we're looking at those LFTs again to say, hey, what's happening? So we're gonna monitor them. Making sure that our patients know that they shouldn't be drinking alcohol, right? Because they're more susceptible to have hepatitis. They're also more susceptible to then get that peripheral neuropathy that we already said would be increased if they were taking isoniazid, right? That was one of those disease states that we were already gonna be worried about. G6PD deficient patients are another patient that we're worried about. Remember, they have that hemolytic anemia that can happen with them. And then they're gonna start feeling that shortness of breath and everything, so we need to make sure that they are not G6PD deficient. And then these other ones aren't too bad, except for that SLE that people can get, or systemic lupus erythematosus. And essentially that's like this autoimmune disease where the body just kind of starts to attack itself, so not great. And it can be precipitated by us having our patient on the isoniazid. So big thing here, neuropathy, hepatitis. Make sure that you understand that we need to give the B6. So anytime you see this, you should see B6 on board with it, because that adverse effect is very common. And then we're gonna make sure that we're also on our empty stomach and we're not doing any dose adjustments. Pyrazinamide, great medication. This one is looking at the synthesis of our fatty acid, and it's stopping that from being made. So essentially it's looking at the cell membrane. Bactericidal, and in our clinical use, we have this in our right. That was a part of our right. Remember, regardless of which phase, the I and our P stayed, right? So this is part of our backbone. Looking at your PK parameters, all of these meds so far, we have been worried about. They said that we had great distribution. What is not the same is that this one you see, we are now worried about dose adjusting. If their creatinine clearance is less than 30, we need to start looking and say, hey, what do I need to do? I'm gonna need to dose adjust, okay? And we would look that up. Adverse effects, we have that hepatotoxicity coming back again, and then they can also experience arthralgias, or those pains, okay, that joint pain. A lot of the times what we'll do is we'll just put them on an NSAID, because it's more important for us to treat their underlying condition, which is that TB that can spread and be harmful to our population. And then you see that hyperuricemia, or essentially the uric acid levels are increasing in the body, and if somebody has gout, they're more likely to experience more flares, or you can put a person to where they actively now have gout, because they're gonna have that uric acid will deposit in their joints. Very painful for the patient. So if somebody already has elevated levels of uric acid, or if they have gout, we are going to be on the lookout, and we can prophylactically treat gout as well. Looking at this with your pregnancy, just ignore this one on this one, because it's telling you that, just ignore it, okay? Different P. Our pyridoxines and our pyrazanamide are not the same thing. Your pyrazanamide is your actual med that is a part of your backbone that we're using to treat TB, and your pyridoxine is added to what? Isoniazid to help with what? The deficiency that causes the neuropathy, right? So it's helping us with our side effects. It's minimizing the side effect. And then looking at our last one that we'll get to today is going to be your ethambutol. So when we're talking about this, again, cell wall inhibitor is my mechanism of action that I'm looking at. That spectrum, same thing, what are we talking about? All these drugs, that's what I want you to remember for your spectrum. We're talking about TB. And then looking at your clinical use, this was what we talked about before when I showed you that backbone, and I said, okay, we have right, but depending on if I'm trying to do my 4 month, then I'm gonna replace my ethambutol, and I'm replacing it with what? What do I add? What's my M? Smart. Okay? So this is just looking at how you're kind of manipulating things and what you're looking at. Your second line therapy, don't worry about that, because I'm worried about y'all knowing first line. Okay? PK, I have another one now that is renally dosed, so that's 2. And my creatinine clearance being less than 30. Looking at your adverse effects, I have something else that is affecting the eye. Don't confuse your optic neuritis with your uveitis, okay? 2 separate things. So when we're looking at our optic neuritis, just understand that the colors and the being able to distinguish the difference between your red and your green are going to be the problem in your patient. So if they start to tell you like, hey, some people I know already have that problem, right? But if they don't have that problem already and they're starting this medication, you're looking at your med to say, hey, this is what's causing that. So if they report any disturbances, visual disturbances that sound like that, you're going to start looking at your med. And then hepatitis. How many times have we seen anything that's messing with the liver? This has been a lot of us worrying about that, right? Your contraindications, not in our kids that are less than 5, so look at the things that I have bolded. Also, if somebody already has that visual impairment with our red-green, we're worried about it. That's what I was telling you. We were already looking at this baseline, and so we don't want to make it worse for those patients. And then if somebody is not able to eliminate that uric acid, so if they already have hyperuricemia, just like we were previously talking about, then I'm also worried about this medication. I can have those gouty flares that can happen in our patients, or I can precipitate the gout. Don't worry about pregnancy on this one either. And then we'll do these tomorrow not tomorrow, because it's Friday. We will do this on Monday when it's not so fresh in your brain. We'll do our check on learnings. All right? Thank you guys. Have a good rest of your day. Don't do the whistle after we're done.